Good morning, everyone. Thank you all for coming today. We're going to go ahead and get started with our cardiology session. Cardiology in the ambulatory surgery space is one that I think is important and one that is growing. And you can see by the attendance in this room, we are still the minority at OEIS. But over time, I think with persistence and perseverance, we're going to start to expand our horizons, so to speak, so that we can be more involved and engaged with OEIS, which is an important society for us in the ambulatory space. So we're going to go ahead and get started, and I have the pleasure of first introducing Kristen Richards. Kristen's the Vice President for Ambulatory Centers with Cardiovascular Logistics, and she's going to speak on building a successful cardiology ASC program. Kristen.
Thank you. Let's see, where do we?
That's a good question.
There's no slides.
Yeah. There we go. Escape key. There we go. There you go. You just
Thank you. Well, good morning, everyone. Thank you for those who came in this morning. This is one of my favorite topics today, is to talk about ambulatory surgery centers, and particularly, I don't know what that is, particularly cardiovascular ASCs. I have been in the cardiovascular space for over 30 years now, and in the last 5 years really just focused on ASCs and OBLs. And so today I want to talk about how or what the process is of building a successful ASC program. Sorry, I'm not doing the slides very well here. There we go. The first, to go on with what Pradeep said, is that I do want to talk a little bit about, kind of set the stage for cardiovascular ASCs. There is a massive shift into this space, and it's growing year over year. And I would say we're still the new kid on the block, but just so you know, it's one of the fastest growing ASC markets today. So we're seeing them all across the country. Some states have been more aggressive than others, but we're seeing this shift, and we're continuing to see Medicare shift more and more cases or procedures out into the outpatient setting, and that certainly applies in the cardiovascular space. We know that this is operationally efficient environment. Patients love this space. Physicians love working in this space. We are going to continue to see growth as the covered procedure list continues to grow. I'm not going to go into great detail about it, but just a couple things about the covered procedure list just this year. Cardiac ablations added to that, as well as complex PCIs, CTOs. So it's a big deal. And then there was, I would say, a complete overhaul of the lower extremity revascularization codes this year. Some of the strategic rationale behind that is the outpatient shift. We are seeing CMS continuing to shift into a lower cost setting. That's absolutely going to continue. We know they're efficient. These are very efficient environments. And again, it's why it's so satisfying not only to our providers, but to the patients. I want to talk now about program planning. And just to set the stage, I think it sets the stage for the discussion for the rest of this morning. But an ASC is not something you just decide we're going to do without any planning behind it, because it takes a great deal of work to do the right thing out the door. And it's not a strategy to build an ASC. If you build it, they will come strategy. You really have to do an assessment of what's happening in the market and know your referral patterns. You need to know your demographics and your procedural volumes. And you need to start the work first to understand, do we have enough physicians? Do we have enough diversity, case mix diversity? Do we have enough referrals? And then how are our partnerships with the hospitals to continue to grow that feed, or any potential competition around you? And then you absolutely have to do some financial modeling. You have to do a pro forma and put all of that together before you would start to do anything. I've heard over the last couple of days folks that have purchased land before they did any of this. They've purchased buildings before they did any of this. And it wasn't always the right step when they made that decision, because once they did a pro forma, they identified they're either going to overbuild or underbuild or what have you. So this is a very important step to understand that, to understand your procedure and payer mix as well. From a regulatory and accreditation framework, this is no joke either. And I'm often reminding the physicians within our organization, we have 3 ASCs that have been completed for the last few months. We are going through the very painful process of all the accreditation process. And they don't magically open overnight. And so there's a step-by-step process. And it's not that you can miss a step. You can't skip a step. You have to absolutely, you got to get your license, right? You got to get Medicare certification, Form 855B, accreditation. You have to have an accrediting body to get your Medicare number. Whoever you use, AAHC, Joint Commission, ACHC, and then you have to have a very compliant program. This is a highly regulated environment. Facility design and equipment. You'll see I didn't have this right out the gate, right? I talked about having a pro forma first and really understanding what you're going to be bringing to the ASC. Then you decide on the space. Then you decide on the size of the space. Don't overbuild. I see that all across the country. I walk into some of these massive ASCs that don't have the volumes at this time to fill the space. So they have a lot of capacity in there. Don't do that. Don't do that initially, right? Make sure that you are matching the facility and your procedure rooms to what you know you're going to be bringing into the facility. So procedure rooms, the support areas, and technology that you're going to utilize. Staffing, clinical staffing model here is critical, and it's equally critical in the OBL environment. Don't get me wrong there. This is a multidisciplinary team that ensures safety and efficiency. This is not, I would say, when you open up a cardiovascular ASC, this is not necessarily a training environment to start out, and it shouldn't be. You should have experienced physicians working in there, as well as experienced cardiovascular teams working in this space, and they are hard to come by these days. They are hard to find. These are hard to fill positions, but you got to have a medical director. You need to have cath lab RNs. You need to have rad techs and RCIS scrub folks. You need to have pre-post RNs and administrative staff. This is bare bones. These are bare bone environments. These are lean environments. They're not heavily staffed. You kind of utilize what you need, but these are critical. And now that we've added cardiac ablations to the list, this has become even more challenging for the ASCs as they're trying to fill roles to ensure that the physicians have the staff that they need to do the cases and provide the highest quality care safely to their patients. The financial and operational, some key levers here is payer contracting. This is important, and you can't pull the payer contracting trigger until you have your Medicare number. The Medicare fee schedule is going to be what it is, but you cannot start any process with your payers until you have your Medicare number. Supply chain optimization. This is not a hospital. These are not meant to be hospitals. So you need to be very smart about some standardization. I know that's a 4-letter word, but that's very critical in your success, that you're being good financial stewards and optimizing the right technology in your environment. Data-driven performance, I can't speak enough about this, and in the ASC environment, this is non-negotiable anymore. CMS requires patient experience, it's mandatory, and they are requiring mandatory quality metrics now every quarter that have to be done. And for the cardiovascular space, it's really focused around patient falls, patient burns, transfers, and complications. Critical. So we have to measure to manage performance, and Medicare has made it very clear that this will become a space in the future that will be incentivized and penalized to do the things that they're doing. Quality and compliance infrastructure, again, this is non-negotiable. You have to have an ongoing continuous improvement process, and that's by measuring and managing your performance through your quality metrics, your patient experience and outcomes. You have to have an emergency preparedness plan, and you have to have ongoing education, credentialing. There's a peer review process. There's focused peer review that has to happen, case audits, safety and risk management. Again, highly regulated environment that when you come up for your accreditation and reaccreditation, these could make or break your facility staying open. So critical success factors. The reimbursement for ASCs is going to continue to grow. Really, it's expanding for higher acuity cardiovascular procedures. And we are still seeing, I talked about it the other day, the hybrid OBLs and ASC models. Those still exist and may be the right case for you. We are seeing, again, more growth in the ASC space because that's where folks are putting and investing their money. The ASC, as you all know, especially a cardiovascular ASC, is a tremendous amount of capital expenditure. Just be prepared for that. And then it is absolutely integrated with value-based care. We're providing the highest quality care in a lower cost setting, providing greater access for our patients and our communities. And lastly, I'll just say that this isn't going away. The train's left the station, and cardiovascular ASCs are here to stay, and we're going to just continue to grow in this space as we see more and more procedures shift into this environment. So with a well-executed plan, you could absolutely build, develop, and execute on a highly valuable cardiovascular ASC that provides, again, accessibility, quality, and sustainability. I thank you all for your time.
Thanks, Kristen. So now we're going to just move on to McCall Walker. McCall Walker is an interventional cardiologist and endovascular specialist at the Cardiovascular Institute of the South. As cardiologists, we always focus on prevention, and he's going to talk about preventative therapies.
All right, good morning, everyone. Thank you, Pradeep, for the introduction. So we'll get started. Prevention first, lowering cardiovascular risk through lifestyle changes and pharmacotherapy. So this is not part of my talk, but as I'm sure some of you have seen just a few days ago, the new 2026 AHA guidelines on management of dyslipidemia came out truly less than a week ago. And while a lot of the themes from these guidelines are going to be in my talk, it's not specifically focused on that. There are 4 highlights here. Number 1 is that we have a new risk calculator. It previously started at age 40. They've now dropped that down to age 30. We have treatment targets that are back for LDL from about 10 to 15 years ago. We now have new goals for apolipoprotein B. Number 3, they're suggesting we test all adults at least once in their lives for lipoprotein A. And of course, there's a strong emphasis on lifestyle changes, and interestingly, a strong emphasis on avoiding supplements, things like red yeast rice, other over-the-counter supplements to treat LDL-C. So what's the scope of the disease? So we know that cardiovascular disease is the leading cause of death in both the U.S. and globally. It's increased about 4-fold from 2000, and it's responsible for about 13% of all deaths in the world right now. We spend hundreds of billions of dollars on this annually. We can align disease and mortality to really 7 factors. I have listed 3 risk factors that we're familiar with on the left and 4 adverse behaviors on the right. Ideal cardiovascular health is considered having all 7 of these factors at goal. As you can see from this bottom statistic, the vast majority of Americans are meeting less than 4 of these metrics. And that's what the focus of this talk is really going to be on. So before we go into that, the first thing that I'll say is there are also some non-modifiable risk factors. We can't do much about this yet, and that would be genetic risk, looking specifically at lipoprotein A, or what we call Lp(a), and familial hypercholesterolemia. I have here on the right an analysis of 3 studies. First, the ARC, or atherosclerosis risk and community study. And you can see that on the x-axis here, we've stratified genetic risk by low, intermediate, or high. And then you can also see the colored bars represent if you have a favorable to unfavorable lifestyle. Regardless of your lifestyle, genetic risk matters when you're looking at 10-year coronary event rates. It's higher with worse genetic risk. This holds true for the ARC study, as I mentioned. It holds true for the women's genome study. It holds true for the Malmo diet and cancer study. Looking specifically at FH, or familial hypercholesterolemia, which we see quite frequently in clinic. If you focus on the green line here, this is heterozygous FH, the majority of what we're seeing. We can really extend the time that these patients have until we see clinical heart disease in them by treating them appropriately. Looking at points 3 and points 4, starting low or high-risk statins on these patients in their teens, 20s, early 30s, we can really get them to mirror those patients who do not have familial hypercholesterolemia. Next is healthy diet. The two diets that have been studied most in the literature have been the DASH diet, which was made initially for hypertension treatment, and the Mediterranean diet. These all focus on vegetables, fruits, whole grains. Mediterranean diet uses extra virgin olive oil as a source of fats and as a source of proteins, fish and poultry. And you can see here that you can reduce both cardiovascular disease and major adverse cardiovascular events with these diets. Taking it a step further, this is one of my favorite studies over the last decade or so. This is the PREDIMED study, which came out of Spain, New England Journal of Medicine publication 2018. Everyone was already on a Mediterranean diet. On the bottom left, we stratified patients to either a diet heavy in nuts, such as almonds, pistachios, a diet heavy in extra virgin olive oil, or neither, standard Mediterranean diet. There is a significant reduction in major adverse cardiovascular events over a 5-year period in those on the two intervention diets, about a 30% relative risk reduction. And on the right, while not statistically significant, you can see that numerically there's lower total mortality in patients who had essentially a tablespoon of extra virgin olive oil per day. Food for thought. So a couple other nutrient-specific things. So things we know about, right? Reducing sodium intake, increasing dietary fiber, replacing saturated with unsaturated fats, decreasing ultra-processed foods, decreasing sugar-sweetened beverages, all have benefit. Next, looking at smoking. Those who smoke on average live about 10 years less than those who do not smoke. If we look at the plot on the right, the risk of any type of cardiovascular subset is about doubled, and it's 5 times higher for peripheral artery disease, which I've circled here. The trend towards e-cigarette use over the last decade may actually be somewhat of a beneficial thing. It may not carry as much cardiovascular risk as cigarettes. And we know that if you stop smoking, you really can reduce your risk within about a 5-year period. There we go. Next is activity. So the guidelines very simply recommend 150 minutes of moderate, 75 minutes of vigorous intensity aerobic physical activity per week. 2 of those days should be muscle strengthening exercises. We can reduce cardiovascular disease by 46% if we do this. Obesity goes hand in hand with that. Again, very simply, meta-analyses, systematic reviews, all consistently show increased risk of coronary disease, diabetes, all cardiovascular disease, heart failure with obesity, BMI greater than or equal to 30, and we can reduce that by focusing on dietary strategies with weight loss. The next few slides are going to be pharmacotherapy on primary prevention of ASCVD. Of course, we know that there are multiple agents that aid in secondary prevention, but again, this will specifically look at primary. What do we have the most data on? Statins. So there are specific populations that are going to benefit most from statin therapy for primary prevention. If your LDL is very high, if you have diabetes, if your 10-year calculated ASCVD risk is greater than 7.5, or if you already have known disease, right? If you have PAD, if you have carotid disease. And I've added this in here, any non-zero calcium score, really focused on a lot in the new guidelines that just came out. If we're still not sure if a specific patient would have benefit from initiating therapy, you can then use risk enhancers, which are noted here on the top right. These can push you towards or away from using a statin therapy. And then bottom right here, calcium score. A calcium score that is 0 may push you away from treating patients with statin therapy, whereas a non-zero calcium score really should be pushing us to treat those patients. Similar with hypertension, right? Leading cause of ASCVD deaths. Pharmacotherapy should be initiated in these patients if they have a high 10-year ASCVD risk and their blood pressure is greater than 130/80, or if their risk is slightly lower with a blood pressure of greater than 140/90. ACEs, ARBs, calcium channel blockers, diuretics, all appropriate first-line therapies. You should base what you use on their comorbid conditions. Probably the most controversial primary prevention tool over the last 50 years has been aspirin. We were giving this out quite literally like candy in former decades. Now, from a primary prevention standpoint, the guidelines really do not support aspirin use except for a very small population of people, those between 40 and 70 who are at high risk of ASCVD who do not have any increased bleeding risk. We should be avoiding routine use of aspirin in those over 70, and we should be avoiding routine use of aspirin in those who have any bleeding signal. What else? Well, we can also guide our aspirin therapy again by using a calcium score. If you look at the graph on the right, the horizontal blue line is the number needed to harm to cause a major bleed from aspirin. It's about 442. Regardless of if your 10-year risk is below or above 10%, if you have a calcium score above 100, you derive benefit from being on aspirin from a population standpoint. So we really should be considering that in our patients. Finally, some novel glucose-mediating agents. These have, of course, been in the news over the last 5 years or so. SGLT2 inhibitors in patients with diabetes, with CKD, and from a primary prevention standpoint, those without diagnosed ASCVD, we can reduce major adverse events, MI, and stroke. It is not actually as clear for GLP-1s. Of course, for secondary prevention, there is benefit there, but for primary prevention, as seen in this plot on the right, it's not totally clear, at least yet, if there is significant benefit from a primary standpoint. So right now, the guidelines would say if your A1C is greater than 7, if you have other CVD, cardiovascular disease risk factors, we could consider with a level of evidence class 2B to start either of these medications. How do we translate all this into clinical practice? Well, if you come into my practice and you're between these ages and you're here for a prevention visit, you're going to get a 10-year ASCVD risk estimation calculated. There's, again, a new calculator to do this, which you can use. I check LPA once on everybody. I always look for tobacco use and cessation, emphasizing healthy diets. We talk about how much activity you should be doing daily. I infrequently use aspirin for primary prevention, whereas I frequently use statins for primary prevention. And of course, we do this with a patient-centered treatment plan. Thank you.
Thanks, McCall. Next, I'm going to invite to the podium Dr. Vinod Nair, who is our complex and high-risk PCI operator, also at the Cardiovascular Institute of the South. He's going to talk to us about the appropriateness of PCI cases at the Ambulatory Surgery Center.
Thank you, Pradeep, for the introduction, and thank you all for being here. How do I get to this? Okay. This morning, what I'm planning to do is to walk you through a framework for patient selection for PCI at ASC. Now, this is by no means an evidence-based data like what Dr. McCall presented here. This is based on opinion. So this may or may not work for your clinic or for your ASC. What I've done is to look at not an established ASC practice, a practice which is probably starting out. So before we go into the clinical selection, I'm sorry. I'd like to look at some regulatory things that has happened in the last year. So in 2025, the proposed rule was released by CMS, which kind of added a whole bunch of PCI procedures that can be done at an ASC. Now, there were some inconsistencies identified, and SCI, Society of Cardiovascular Interventional and Angiography, had kind of sent a letter to them noting that, for example, atherectomy alone, there was no billing code, but atherectomy and stenting. So if you do an atherectomy and do balloon angioplasty and get a good result, there's no billing code for that at ASC. November 2025, CMS came back and included most of the PCI procedures in ASC that can be done at ASC. However, they also made something very important, which is 5 exclusion criteria, which so far prevented physicians from doing certain procedures at ASC. They lifted it and switched it to physician responsibility to decide it. And what those 5 are, these 5, of which number 3 was what was probably last 2 decades keeping patients away from outpatient facilities, which is directly involve major vessels of the heart. Now, the inclusion criteria shifted from CMS decides to physician decides. While this is very good because we get to do a whole more of procedures at ASC, this also shifts the regulatory and legal risk to the physicians. If you get into a complication at ASC, and if that case could have been more safely done at the hospital, then there is some legal liability there for the physician. Now, keeping that in mind, we propose a phased conservative approach. Because the regulatory landscape is still evolving. As Kristen mentioned, this is the largest ASC expansion in the history of the United States, and we have very limited data specifically on atherectomy. SCI 2025 data shows only 2.4% of the total PCIs done at the ASC in US had done any sort of atherectomy. So we don't really have much data to talk about it. Now, as I mentioned earlier, physician now owns liability for site of service determination. So this is a criteria that we adopted at CIS, and we plan to look at the evidence. We are monitoring our metrics. We plan to reassess it in 12 to 18 months and then redecide what we need to commit to. So the high-level overview will be single vessel PCI, ischemic heart disease with stable symptoms, abnormal perfusion scan with at least a moderate perfusion defect, and preserved LV function. Atherectomy, do it in select cases with mild to moderate calcification in a non-CTO, non-graft vessels. Build the evidence over time and participate in ACC registry as well as our internal registry, and reassess in 12 to 18 months as real-world data emerges. Keep in hospital those cases with heavy calcification, CTO, vein graft, reduced left ventricular systolic function, and electively needing mechanical support. So which patients to exclude? This is kind of common sense: STEMI, non-STEMI, cardiogenic shock, severe LV dysfunction, complex multivessel disease like CTO, unprotected left main intervention, vein graft lesion, high-risk bifurcation lesions, which may change. We don't have, even though IVL is approved, and I understand there will be a talk about it later, we don't have a code to bill IVL at this time. Complex bifurcating lesions may change once IVL is available in ASC. And obviously, elective need for mechanical support, as well as in patients with advanced CKD, who we anticipate high contrast load. Now, this is an example of a case you shouldn't do in an ASC, at least in 2026. It's a patient who has a JCTO4 RCS CTO who's filling via collaterals, epicardial collaterals, and retrograde collaterals from the left. These patients are normally very sick. When you have this much of calcification, it's going to be difficult, and you can get in trouble. Even in the hospital, you can get in trouble. And so this is what you're seeing. That particular patient, you're going retrograde and you already exteriorized the wire here. And for people who are not familiar with CTO PCI, this is a left guide. The wire is crossing through the septal towards the right side, and it's exteriorized through the other side. In this particular case, the catheter got stuck there, and there's no way to get the catheter out 3 hours into the procedure. And the doctor, that's me, struggling to push this catheter out. And somehow we were able to get it out with a high contrast load, 4 to 5 hours of procedures. It's clearly not something that we want to be doing at the ASC. Now, what about antegrade approach? Antegrade approach is usually built as a safer approach, but if you look at the recent Open CTO registry, which was released and then a new data available in 2022, is that 6 out of the 10 clinically significant perforation did not occur from retrograde approach, it occurred from antegrade approach. So even antegrade approach, if you think you can easily do an antegrade CTO PCI, in 2026, we believe probably this shouldn't be done, should be left at the hospital. I do understand there is billing code available for it, but this is something that we probably should stay away from at this time. Now, this may change as we get more data, and across the United States, not just CIS, we will be able to see more data about it. So ideal ASC PCI candidates will have an elective PCI indication, single vessel non-complex coronary artery disease. In selected cases, it's appropriate to do atherectomy, preserved LV function preferred, low bleeding risk radial access preferred, no patients with significant advanced CKD, social support and same-day discharge possible, experienced interventional cardiologist on site, and lives within reasonable distance from the hospital. Now, key consideration is pre-procedure risk stratification. I think this is important. Case selection is extremely important in ASCs, PCIs. Review clinical angiographic and demographic data and confirm operator experience matches the case complexity. Transfer protocol should be established for patient to be transferred to the hospital. One of the things that is concerning is because we are worried about perforation specifically in PCI, there might be a tendency to underdilate stents in ASC, which is understandable because you don't want a perforation. But I think that that's not good, as we all know. For that, the right thing to do would be to use IVUS, intravascular ultrasound, very liberally and match stent sizing. And if you find a concentric calcified lesion, you don't think is balloon expandable and we don't have IVL, it's probably better to stop that case and refer the patient for a hospital procedure because they are the ones who get us in trouble. And stent size optimization is very important. And post-procedure, and another thing is that if you do see calcium and IVL is available, it's very appropriate to try it because our data experience from IVL is very good in the hospital. Very less risk of side branch loss and very high likelihood of technical success if we have IVL available. Post-procedure discharge data, we at CIS observe from 2 to 6 hours depending upon the complexity of the procedure. We need to make sure dual antiplatelet therapy is loaded and prescription is filled before discharge. And our protocol is to call patient within 24 hours to check on them and a clinic visit within 2 to 4 weeks. So the ideal patient to say yes would be stable angina patient, single vessel preserved EF, low bleeding risk, adequate renal function, experienced operator, robust transfer protocol, intravascular image guided lesion assessment and stent optimization, and social support and for same-day discharge. Say no for complex patients, and as always, patient safety is the guiding principle, and when in doubt, say no. Thank you.
Thanks, Vinod. Now we're going to bring Aaron Gopal to the podium. Aaron, we're getting our South Carolina contingent from Spartansburg in the next 2 talks. Aaron was one of our former fellows in endovascular intervention with Craig Walker, and he's going to speak on physiology and imaging and PCI, which is a thoughtful way of treating patients with coronary artery disease.
It's nice to meet you all. My name is Aaron Gopal, and like Dr. Nair said, I was a trainee under him and Dr. Walker, Dr. Fail over here. They all taught me for a year, and it was a very fruitful year. But here I'm discussing, it was more about peripheral arterial disease, but here I'm going to discuss a little bit about percutaneous intervention, physiology, and imaging. So this is just a summary of the talk. So why is angiography insufficient in and of itself? You know, we all know when we do angiography, we're essentially doing a luminogram or luminography. We're providing a silhouette of the lumen. We really don't assess plaque burden very heavily unless you see something that's substantially severe. Composition is very difficult to identify, on fluoroscopy alone, unless they have a ton of calcium, which you can see fluoroscopically, or if you have eccentric plaque distribution. There's the Glasgow phenomenon, which you see on the right, where you have remodeling of the blood vessel. You have compensatory enlargement, which masks plaque burden. You can see here that on the angiographic view, it doesn't look like a severe stenosis in this circumflex. But when you look on the IVUS, you see a pretty heavy plaque burden there, and you see the positive remodeling. You can suboptimal stent sizing often occurs when you just use angiography alone. And if you look at the literature, in up to 40% of cases, you see undersizing of stents, which increases the risk of malopposition and underexpansion. There's also a functional uncertainty. We know that there's a large divide in the visual estimation of intermediate stenoses, and that's where physiology plays a large role. What looks like a mild narrowing can really hide a vulnerable plaque or significant burden, which will alter your treatment strategy. So with regards to imaging, there are two major imaging modalities that we use in coronary disease, which I'm sure everyone in the room knows. There's intravascular ultrasound and OCT, and there's even more subsets when you talk about intravascular ultrasound, whether we're talking about phased array or rotational. So with IVUS, typically the resolution is a little bit less than OCT, but the penetration depth is a lot higher, which is why we use it in peripheral arterial disease. You require blood clearance with OCT, whether it's through contrast or with saline, which we're using more and more in low contrast PCI. With vessel sizing, IVUS, you can very clearly see the EEM, the external elastic membrane. With OCT, it's pretty good. You can see the lumen, and the EM, it kind of varies. Calcium assessment, both are pretty darn good. But with OCT, you can see it with a little bit more detail because it's fairly well circumscribed. Thrombus, it's a lot more easy to delineate with OCT, especially when you're looking at red, erythrocyte-rich versus platelet-rich thrombus. With regards to lipids and thin cap fiber atheromas, you get a more attenuated signal on IVUS, but you see it fairly clearly on OCT. With stent apposition, they're both pretty darn good, and with dissection, they're both good, but OCT tends to be a little easier to interpret. As far as osteo and left main disease, we typically use IVUS, because that has the best data. So, the strengths of IVUS, you get deep tissue penetration, you get a little higher resolution with OCT. So with regards to IVUS, typically we do it for pre-PCI assessment. We look at the vessel size. We measure the external elastic membrane to external elastic membrane diameter when you size your stents, and then you typically size maybe a 0.5 millimeter down or a 1/4 millimeter down. For plaque burden, you assess the severity of the lesion. Left main assessment, you look at the MLA. And then morphology, especially when you're crossing CTOs, it's very helpful to distinguish whether or not you had true crossing versus subintimal crossing. And you also assess calcification. So here's a typical IVUS photo, and you see the lumen, you see the artifact by the IVUS catheter, you see the intima, and then that black line, the media, or the EM, and the adventitia outside. So this is normal. And then here you see fibrocellular plaque, which is not very echogenic. And then you start to see fibrocalcific plaque, which is far more echogenic, and you see dropout behind it. And then pure calcific plaque here, which appears as very white with a lot of dropout. And then, of course, post-PCI. We use it for optimization. We check the stent expansion. We make sure that it's over 80% of the reference lumen, or EM. Malapposition, a gap between the strut and the vessel, which substantially increases the risk of stent thrombosis. Edge dissection, identifying major flaps that, you need to cover or treat. And, of course, geographic misses. You want to make sure you're landing in a healthy zone, proximally and distally. So here you see a very, it's a little bit difficult to visualize, but you see a medial dissection flap here after ballooning. And then here you see a little bit of stent malapposition. And then over here you see a lot of tissue protrusion after placing the stent. So with OCT, you get a little bit better resolution, so you can really identify lipid plaque pretty well and TICFAs. You can see calcium assessment where it's very well circumscribed. So unlike OCT, it's not something that you see dropout in. You see this well circumscribed structure. And then, of course, for thrombus, you see a very clear differentiation between red and white thrombus, which is very important. I had a STEMI case recently, a new onset atrial fibrillation, didn't have much atherosclerotic disease, and his LAD was cut off. And if I hadn't had imaging, I wouldn't know what the treatment strategy would be. I didn't know whether or not this was plaque rupture or embolization. And with OCT, I was able to visualize that red thrombus very well. So we just used aspiration and left it alone and put him on anticoagulation. So it really does help you with the treatment strategy. And with OCT, at least this is a fairly clear view of the intima, the media, the EM, and the adventitia. And of course, for post-PCI, it's very helpful for optimization. You want to look at stent expansion again, malapposition, look for gaps, tissue prolapse when you place your stent, and of course, distal edge dissection. So here you can see a very clear-cut dissection post-PCI. Here you see some under-expansion malapposition, and then here you see some tissue protrusion post-PCI, which really changes your treatment strategy. So with regards to physiology, there are multiple different modalities that we use. Of course, everyone in the room is familiar with FFR. That's the original hyperemic index. You give adenosine peripherally, and you measure the fractional flow reserve. Anything under 0.8 is considered ischemic. Over 0.8 is considered non-ischemic, and it's the gold standard for functional assessment. But they came up with something that improves your workflow, and it's helpful, especially in the OBL setting. Where it's not inferior to FFR, that's IFR. And of course, there's RFR as well through Abbott. And in defined flare and IFR Sweetheart, they found non-inferiority to FFR. But unlike with FFR, you don't have to create a state of hyperemia, so it speeds up your time to assess the lesion. Anything under 0.89 is considered significant, and anything over 0.89 you can defer safely. At least in my algorithm. If it's borderline 0.9, 0.91, I'll typically switch to a hyperemic index. And now we have microvascular assessment. So in our lab, we have the Abbott system, and we can measure the coronary flow reserve. And it's very helpful in these patients that present with Minoka or anginal symptoms despite not having any sort of lesions on CT previously. We measure the CFR. Anything under 2 is considered abnormal, and then there's, of course, IMR and MMR, which are both emerging. With FFR, the data was fairly robust. It initially started with defer in 2001, which essentially showed the safety of deferring PCI when the FFR is over 0.75. But of course, that threshold changed after FAME 1, FAME 2. And so with FAME 1, they compared FFR guided versus angiography guided multivessel PCI, and there was a 28 relative risk reduction in major adverse cardiovascular events at 2 years. And then FAME 2 came out, which kind of just essentially bolstered the results of FAME 1, and there was a significant reduction in urgent revascularization when compared with optimal medical therapy. About a 38% reduction in unnecessary stenting with FAME 1, and the number needed to treat is fairly low, only 7. So you look at the 5-year MACE rates, FFR-guided PCI was significant compared to optimal medical therapy alone. And then, of course, with IFR and the resting indexes, you have the defined flare, which just showed that it was non-inferior to FFR with really just a 0.2% absolute risk reduction in MACE. IFR Sweetheart confirmed also the non-inferiority, which makes it a very viable physiologic test. And the nice thing about it, no adenosine is required, and it's much faster. And like I said, at least our algorithm, if it's borderline, that's when we switch to a hyperemic index. And the nice thing about it is you get pullback co-registration, so you can see where the predominant gradient is, and it helps prevent unnecessary stenting. And there's something called the pullback pressure gradient, where you take the total change in pressure across the lesion versus the total change in pressure across the entire vessel. And anything over 0.83 is considered focal, and in those patients, they tend to do better with PCI. But when you start to see it lower below 0.83, it's more diffuse disease, and that's when you consider more optimal medical therapy or even CAB in certain circumstances. And in post-PCI, the functional gain really does impact the major adverse cardiovascular events when you compare the two between focal and diffuse disease. What do you want to treat, essentially? So these are the pivotal imaging trials. So you've got Ultimate in 2018. It compared IVUS and angiography, and there was a significant reduction in target vessel failure, about 2.5% absolute risk reduction. So the number needed to treat is 40. And, you know, a lot of people in this room are doing at least 200 PCIs a year, you know, so that really does matter. Illumian 3 came out, and it compared OCT and IVUS and essentially showed that OCT was non-inferior, so it's a good adjunctive imaging modality. With Renovate Complex PCI, they looked at IVUS versus OCT, IVUS or OCT versus angiography and complex coronary lesions, and you know, I think that's where imaging really benefits, and you see a major reduction in target vessel failure at 2 years. There's Illuminate 4 and Octavius as well. And this was just a meta-analysis which showed IVUS-guided PCI versus angiography, and you can see that, you know, target lesion revascularization or definitive ST wave changes, there was a substantial reduction in those outcomes when you used intravascular ultrasound. The same thing in OCT. You know, with the Houston Methodist study, there was a 60% reduction in all-cause mortality at 3 years, which is primarily driven, you know, by imaging. So, of course, the guidelines updated, and that was fairly recent. ESC was a little bit ahead of the American College of Cardiology guidelines, but in 2024, they made it Class 1 with a level A of evidence where intracoronary imaging is recommended to guide PCI, especially in complex lesions. And they also said that physiology should be used in any sort of intermediate grade stenosis, which they determined anything between 40 and 90%. And then, of course, ACC followed suit in 2025, and intracoronary imaging should be recommended, should be used when you're treating acute coronary syndromes or complex coronary lesions. And what are the complex lesion subsets? Of course, left main disease. I think that's where it's really crucial, because you really want to ensure that you're really expanding the stent properly and you're not having any malapposition. So you look for the MLA threshold of 6 millimeters squared in the ostium or shaft of the left main, or at least 7.5 in the distal bifurcation. Bifurcation lesions, imaging is very helpful because it can help predict plaque shift, you know, based on the morphology of the bifurcation lesion, and determine whether or not a provisional strategy is appropriate versus a mini crush or a culotte. Calcified lesions, it's very helpful. Oftentimes with fluoroscopy alone, you'll kind of know that it's not going to expand fairly well, but this just helps you, this helps give a little bit more information regarding that. You look for a calcium mark over 180 degrees, a thickness over 0.5 millimeter, or a length over 5 millimeters. And anything more than 2 points, you probably want to use some sort of plaque modification, whether it's intravascular lithotripsy or atherectomy, whether rotational or orbital. And CTO is very, very helpful. You know, identify the proximal cap and look at your crossing, especially if you're doing an antegrade, whether or not you're in the true lumen or subintimal, and it helps you guide your reentry point. And of course, for in-stent restenosis, which I think is the most helpful because it helps you determine the mechanism of the in-stent restenosis. You know, if it's neoatherosclerosis, you know, that's something that you want to treat, you know, typically with second stent. Whether if it's under expansion, then it's more mechanical. You know, that's when you use ultra high pressure balloons or OPN or lithotripsy. And then of course we have drug coated balloons now when people develop neointimal hyperplasia. So stent optimization. There's pre-PCI imaging, you know, and then of course it helps you with stent selection, and then we typically use it afterwards for optimization. So we try and integrate as much as we can. We use physiology first, then we use imaging pre and post. And this is just another slide showing you the microvascular physiology. And there are a lot of future technologies that are going to be coming out in the near future. You know, trimodality, AI assistance. You know, we're actually going to be getting the Abbott system fairly soon, which integrates all of this and tells you exactly what to treat and how to treat it. And there are a couple other things. And this is the typical workflow that we use. So, you know, someone comes in for a PCI. If it's anything in the moderate range, we use physiology first. If it's not significant, optimal medical therapy. If it's significant, we proceed with PCI and we use imaging, whatever imaging is preferred. And so, like I said, angiography alone is insufficient. Physiology really helps you determine functional significance and allows you to defer safely. And now it's a universal class 1 recommendation for both physiology and imaging. These are my references. Thank you.
Thanks, Aaron. All right, we're going to move right along to Brian Brown. He's an expert in multiple interventions in coronary, venous, arterial work. Thanks for coming. He's going to speak to us about atherectomy and IVL for PCI. Thank you.
Thank you. It's a real honor to be here this morning. Really proud of you, Aaron. Great talk. McCall, yours was excellent as well. Those are the only ones I heard so far, so those are the only ones I can comment on. So this talk is really broad, atherectomy and IVL, and I wasn't really sure what you wanted me to talk about and if it had to do with ASC, OBL, the hospital, but I have a few thoughts I want to share with you all. Now, I did upload my slides. If they're not here, that's okay. Okay. All right, thank you. So, IVL, atherectomy, and then you see there it says rhodotripsy. I kind of hate hashtag acronyms, but there it is. So where did I start to use atherectomy in the coronaries? I trained at University of Wisconsin, then I went to Brown. I remember one of my first cases was with Paul Gordon, who trained with Don Baim, and the patient was coding, and he said, "Bring me the rotoblader." And we get to the lesion. To me, atherectomy, when you're a busy operator, is delivering the stent. It's not about luminal gain to me. Other people are different, so this is opinion. I had a Japanese physician that flew over and met with me at my OBL, and I said, "How do you use CSI?" And he says, "Well, we use OCT, then we use CSI. Then we OCT again, then we use OCT. We look, and they're literally shaving that lumen and making it bigger and bigger and bigger." To me, it's about being able to deliver your final solution, which at that time is a stent. In the future, could be a drug-eluting balloon. Some of my partners had used directional atherectomy in the coronaries, which actually still exists in Japan. Not in the US anymore, it exists in the periphery. And that's kind of interesting to me as well, because in a soft plaque, that makes a lot of sense. I think for calcific plaque, that's very difficult. There's a lot of differences between rotoblader and orbital atherectomy, and orbital atherectomy has limitations when it comes to physically getting through the lesion. It is not front cutting. It shaves the lumen. It cuts down that intraluminal calcium so that you can deliver the stent that you want to. Rotoblader, I think, has decreased usage because it's a pain. You have to be able to exchange for their 009 wire, and that wire is very, flimsy, you could say, and once you bend it, it's a real problem. But the orbital atherectomy wire is nitinol, and so I use that as a primary wire when I'm wiring. When I look at an image up front, I like efficiency in the cath lab. So if I see a lesion that I know I'm going to struggle to deliver a stent, I just call for that wire. I wire with that. I do orbital atherectomy up front, and then I go ahead, and if it's lithotripsy nowadays, or if it's delivering a stent, that's what I move on to. So, like we were talking about, impaired stent delivery, stent under expansion, these are reasons to use atherectomy and IVL, but they come with complication rates that are a little bit higher. I think a lot of the decreased usage had to do with reimbursement, frankly. A PCI was, I think, 10.9 RVUs, and a atherectomy is 12.31. IVL comes on the block, you get 3.47 per vessel. And so IVL usage increased, I think, a lot due to reimbursement, but most of us are good people. We're using it because we're able to expand the lesion at a low pressure. This I've been learning about more recently is the actual calcium arc. So we're trying to enroll for tectonic. You need 270 degrees of calcium on OCT to actually be able to enroll a patient for their IVL balloon. So I don't need to talk about imaging because Aaron already talked about imaging, but I think it's a good thing to do to educate ourselves. What is this lesion? What does it look like? What is it made out of? All right, now it's moving. All right, so back to rotational atherectomy and orbital atherectomy. How many of you use this for a show of hands? Either one in the coronaries. How many of you only use one or the other? Okay, that's interesting. So why is that? You both raised your hand and said you use one or the other. Which one is that and why? Excellent. And you talked about maximal luminal gain. You also raised your hand. You use one or the other, and which is that? Rhoda. And is that based on what they said, or is there something different? Okay. 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 I think Rhoda is actually probably a superior technology in the coronary space, but again, there's the ease of use issues. But to me, it's really about delivery, and so orbital atherectomy really does shave the lumen down so you can deliver things, but I do not use it for luminal gain because we're going to use high-pressure balloons or we're going to use IVL, and so that's just my personal opinion, but the biggest limitation of orbital atherectomy is actually getting through a really tight calcific lesion. It can't do that because it's not front cutting. All right, back to the acronyms. Rhoda-Tripsy. When the balloons first came out from Shockwave, they were quite bulky and they were hard to deliver. And so it's frustrating because you essentially had to do an entire percutaneous coronary intervention before you could even deliver the IVL balloon. Again, back to why I started actually using more atherectomy than I used to, just so I could deliver an IVL balloon. They have newer generations. I have not used seismic yet, so I do not know its deliverability. I do know the limited market release of Shockwave's balloon is more deliverable. And Tectonic, the Abbott balloon, is more deliverable. But I think that it's really exciting to be able to use a balloon that treats the vessel and put it at low pressure. My whole training was above rated balloon pressure. There are some people that train places where they are afraid to go above rated balloon pressure. The concern for that, of course, is perforating the coronary artery. I was at this brewery, and my partner called me. He said, "Brian, I delivered this stent. It won't expand. What do I do?" I said, "Keep going up in the balloon." He said, "Well, I went up to rated." I said, "Dude, 24 and down, brother." He goes, "Should I keep going up?" I said, "Look, two things are going to happen. Either that stent's going to expand or you're going to perforate the artery. If you perforate the artery, you just need to be prepared as an interventionalist to take care of the problem. What you can't do is leave that underexpanded stent in that proximal LAD." So again, I was a little bit frustrated with lithotripsy balloons when they came out. My first lack of belief actually was in the periphery. If you remember, the peripheral balloon was used a lot in TAVR procedures. So they'd have a 7-millimeter balloon, and they would expand it at 2 atmospheres, 4 atmospheres, and it said, "This thing's incredible. Look at this." I said, "Well, the vessel's bigger than 7 millimeters. Of course it expanded at 2 millimeters or 4 millimeters." I am a full believer in IVL. So since that time, I used a lot of it. And I use it in the coronaries, I use it in the periphery, I use it all the time. And I had a friend come to argue with me. There's some Boston trial looking at IVL versus the Wolverine balloon and expansion of a vessel. And I said, "You got to be crazy." First off, people are not going to quit using IVL. One, there's reimbursement associated with it. Two, there's comfort. If you can put a balloon up at 4 atmospheres and fully expand a lesion instead of 24 or above, why would you not do that? So it works. I think it's very safe. If we're talking about the ASC space, we just heard there isn't reimbursement for this, but I would say I'd feel a lot more comfortable using IVL in my outpatient facility than I would atherectomy, despite using a fair amount of atherectomy. And then one last caveat before I end. My esteemed colleague right here I met yesterday, he said, "This society is not just for ASCs and OBLs, it is about outpatient care." So think about what you do for outpatient care. A lot of what you do at the hospital is outpatient. It's same-day PCI, whatnot. So I think IVL would be great to have reimbursement in an ASC. I think it's fine to have atherectomy reimbursement, but you need to understand what you're doing and what you're risking for the patient. Thank you very much.
That was great, Brian. Thanks for keeping us on time. And now, a guy that doesn't need any introduction. I'm going to call Fadi Saab, a true thought leader in our field in CLI. We're going to have him change hats a little bit to his interventional cardiology hat and talk about complications.
Thank you, Pradeep, for the kind words. And thank you guys all for being here today. So I'm going to switch gears a little bit about when the Empire strikes back for the geeks out there, myself included, for Star Wars. All right, so I actually currently work in an ambulatory surgical center, and part of my practice is taking care of patients with coronary artery disease. And all of the benefits extends to working in an outpatient environment, especially in an ASC. But when you start thinking about complications of percutaneous coronary interventions, it's probably beyond the scope of our talk today. But nonetheless, these are some of the things that we want to think about. Or when you walk into a room, these are things that you want to be prepared for: arterial access, coronary perforation, no reflow, tamponade, contrast allergy, some medical issues like respiratory failure or acute heart failure. So just to name a few. Now, should anyone be obtaining access without the use of ultrasound in 2026? Unfortunately, this remains happening nowadays, and I would say a lot of the cardiologists are guilty of that, not our colleagues. Sorry if you're squeamish a little bit, but this is an image I always show. I'm not a surgeon, and one of my colleagues, Dr. Plagueis, actually is going to be speaking the next session in one of our cadaver labs, showing the femoral head and then showing the common femoral artery, the superficial femoral artery, and the deep femoral artery. And this is really a telltale image because this concept of compressibility is extremely important. For the longest time I was training, they say you cannot do anything unless you cannot access the superficial femoral artery. You have to always access the common femoral artery. And part of it is dogma or pragmatic, but the most important part, in my opinion, was the issue of compressibility with the vessel. I'm going to elaborate on this a little bit. So this is an image of the common femoral artery with the bifurcation in the superficial femoral artery and the deep femoral artery. And you want to clearly visualize your access point. So this is an example of our needle with the wire through the needle, hugging the posterior wall of the common femoral artery. So I'm not guessing anymore where my access point, because if there is a complication, I'm not going to guess where the complication is being generated from. So safe exit strategy. Now, not all common femoral arteries look this way. These are some of the common femoral arteries. Patients with coronary artery disease have all these comorbidities, and obviously we're more predisposed to having peripheral vascular disease. So this is a common femoral artery. I can see where the calcium on the posterior wall here, and I can avoid that area if I need to access that segment for the patient. So if you see it, you can definitely avoid it. So that's why, advocating for the use of ultrasound is something that's very important. Now, this is an image I show to my fellows quite a bit, because the idea is, we're looking at the common femoral artery. We want to obtain access there. But you're not just only visualizing the vessel. You're looking at the vessel pulsation. Are you able to compress the vessel? You're looking at the size of the vessel. If you're considering antegrade access, and you're looking at closure technique. And this is what you saw in real time, us accessing the vessel in the short axis view and then the long axis view with the wire through it. Now, this is the same vessel, same patient. So what we did is we looked at the segment. This is the concept of compressibility that I was talking to you about, using the same probe. I want to make sure that even if I don't use a closure device, when I put my hand on that groin, I'm not going to have a complication. And this is very important when you're working in an outpatient environment, because we're not keeping those patients overnight. We want to send them home, and we want to send them safely home. In the same patient, you can see just going up 1 centimeter, I'm compressing with the ultrasound probe, but there's clearly almost 180 degrees of the vessel. This area here is compressible. This area here is not compressible. Again, the importance of using ultrasound in obtaining access, and it shows that why some of these access points fail miserably despite a great intervention. Now, this is another example of using ultrasound, and I will tell you, the day I came to the meeting at OEIS on Tuesday, I did not do what I preach. I did not use ultrasound to visualize my perclose closure, and I had a complication that day that I had to go from the other side and salvage it in a peripheral patient. So this is an example of, anybody can guess what closure device this is? Any of our cardiologists? Say the name. Anybody? Something we use all the time. There's something moving back and forth at the bottom there. What was it? It's a perclose closure device. So these are the foot plates of a perclose closure device coming against the anterior wall, so I know I can deploy it nicely there, and I'm not guessing. All right, so let me show you a case. I knew on Saturday morning we need to get people's blood going. This is a patient that came in for a procedure. She's in her 70s. This is a diagnostic heart catheterization, the right coronary artery here, and the left anterior descending artery here. And the lesion that we were going to treat is in the proximal left anterior descending artery. And things work out nicely. Did not require a atherectomy. Did some few post dilations. There is a twist in the LOD down there somewhere. This is this was not a run-through wire. I usually use a run-through wire in some of my interventions. And there. So what would you do here? This is it's a distal perforation. It's a frank perforation. It's, I would say, what do you think, stage D on the scale. And one of the concerning things is the contrast is clearing, right? So this is not something that I can treat conservatively. And even in an ambulatory surgical center, you have to be prepared to address some of these concerns, address some of these problems with appropriate tools. And when that happens, you have to be prepared to use. There's a variety of balloon expandable covered stents. In our lab, we use the Biotronic PK Papyrus. I think it's slightly better deliverability than the GraftMaster. But however, you just got to be prepared that you have to have appropriate documentation in terms of why did you use it, how did you use it, so on and so forth. And in this particular patient, patient remained hemodynamically stable. We performed the stat to the echo, despite the patient remaining stable, we decided to transfer the patient to the hospital, and we discharged them within 24 hours. But the point from showing this complication is you have a process, you follow the process, and ultimately you save the patient. Even if I was in the hospital and I wanted to discharge, this was an elective procedure, I wouldn't have discharged the patient. I would have kept them for 24 hours to monitor them. Okay, let me switch gears a little bit. This is, even though we do coronary interventions, this is a CLI patient, and they required cardiac catheterization. It's unfortunately the nature of the disease combined. They have coronary and peripheral vascular disease, large BMI, central obesity, and the patient required an LOD intervention. All right, and I'm just showing you here the anatomy of the patient on the other side. This is from a previous intervention that we had on the patient. This is the device called the Sync device. Will be available soon. But anyway, we're done. We're, as usual, everybody's high-fiving each other, and compressible site. The patient, I didn't like how the vessel looked diseased after the heart cath, and we took the patient to, decided to do manual compression. And the staff comes to me and tells me that the patient is having bleeding. So I immediately felt that we are in no control, we're not in control of the access site for the patient, and brought the patient back to our cath lab. And this is the image that we see here. Now this is what we call an LAO orientation, showing us the anterior wall of the vessel and showing us this patient has a high bifurcation, so showing us where the access point is. It was helpful because I had an image showing me exactly initially my needle through the wire where it is, and I can see where the perforation is. This is the balloon tamponade there, and my hand on my tech hand, we alternated the radiation exposure. But ultimately, we decided to put a self-expanding stent. So this is just a bailout strategy for this patient, and this was the final result for the patient. Patient did fine. Now, what I want to show is something that you can actually do, and this patient actually left home the same day. But this is a hematoma in the thigh area where the patient was bleeding. And this is a maneuver that I tend to do even in peripheral cases because complications happen. So under ultrasound, I will identify the collection of fluid. It's really for the comfort of the patient, because if you leave the hematoma there just for weeks, for months, sometimes they're really uncomfortable. So I identify a loculated area, and then I will place an angiocath and kind of drain. And you can drain, it's not a large amount, you can drain 5 to 10 cc's, but it makes a big difference in terms of the patient comfort. So in conclusion, complications will happen, need to be well prepared. Running drills with the staff is very helpful. I do that all the time. When if you have a complication, actually we debrief together. Early recognition is key, and transfer when appropriate. Thank you.
Thanks, Fadi. All right, so let me get to the main screen here. My talk is interventional cardiologists in the endovascular arena. Why it makes sense. It's a little bit of a philosophical talk, but I think it's important. It's something I'm very passionate about. Disclosures. All right, so the purpose of this talk, it really stems back about a month ago. Bob Tahara, former president, previous president, OEIS, posted on LinkedIn about there was a National Center for Health Workforce Analysis showing that vascular surgery specialty, the numbers are going down, and in a decade there's going to be a shortage. And this is especially true in rural areas. And I'll say that, when you look at the overall numbers, every specialty is going down. Even cardiology is going down, but we're going down at a slower clip. And cardiologists are really available because of the increases of PCI without surgical backup really all over the country. So we are available throughout there to help treat patients. But the problem really is if we don't have vascular specialists, the issue is we're going to have an uptick in amputations. If you look at Mary Yost data, the prevalence of PAD is around 22 to 25 million. And this really is correlated with the increase in diabetes. Sadly, peripheral artery disease is still misdiagnosed by primary care at a high clip. Major amputations are happening as the first and only therapy in many areas around the country. We're underutilizing diagnostics, leading to no angiograms prior to major amputations. Revascularization is still to this day underutilized, and there is a low referral to vascular specialists before patients have major amputations. And if you have lack of vascular specialists, you're going to not only have more amputations, but you're going to have more deaths. As you can see, amputation rates is directly correlated with death. And essentially, the worse you are in Rutherford classification, the higher the risk of amputation. We are seeing more and more patients that are younger with peripheral artery disease and CLI. I'm seeing it in my practice. I'm sure my colleagues are seeing it in their practice. More women present as their first presentation with critical limb ischemia. And Black Americans, unfortunately, have worse outcomes. They're a third of the population of CLI, but they do far worse. So I'm just going to mention, there was a concept that was posted by Society of Vascular Surgery, which was a few years ago, in regards to an article that was placed in a newspaper. And the final statement in this statement by the SVS was that There is only one primary specialty in medicine comprehensively educated, trained, and tested to provide this full spectrum of evidence-based care to vascular patients, ranging from medical management to minimally invasive procedures to open surgery, and that specialty is vascular surgery. And it really gave me pause for thought because I really wanted to, you know, I don't do open surgery, and I think vascular surgeons are critically important to as a vascular specialist in this space, but where do I fit in? That is something that I wanted to better understand. You know, peripheral artery disease is not an isolated disease. 30% of patients have PAD in isolation, but it is really a polyvascular disease. Patients with PAD have concomitant coronary artery disease or cerebrovascular disease. And so we have to really think about what interventional cardiologists truly are. Who are we? Well, we start with training of 3 years as an internal medicine resident. We are board certified internists, gaining knowledge in a variety of specialties within internal medicine and chronic adult diseases. And so these are very valuable tools and foundational tools for treating patients with chronic limb-threatening ischemia. Who are interventional cardiologists? Well, we are first board-certified cardiovascular disease specialists. We spend 3 years in dedicated training where we really focus a lot on what McCall was talking about with prevention. But then we learn about various aspects of cardiovascular disease and electrophysiology, critical care, imaging, valvular heart disease, and even some training in vascular medicine and heart failure. But what I can tell you is that when you decide as a cardiology trainee to go into various specialties, interventional cardiologists spend a year dedicated, really, in many training programs focused on the heart. But we are board-certified interventional cardiologists that are dealing with complex disease like myocardial infarctions and shock, patients who are critically ill. Fadi mentioned vascular access site management, coronary interventions, arrhythmia management, things that, and structural heart is gaining strong momentum within the interventional cardiology field. But one thing that we are all taught from day one of our interventional fellowship is to how to be gentle with your hands. Finesse, technical skills are built into our fiber as interventional cardiologists. So as we move forward, we have cases that we can treat. I'm sorry. Let's see here. You know, we learn about STEMI and patients that come in, bread and butter PCI. We have to be prepared to treat these trifurcation lesions or occlusions that come in at the same time. We have patients that are more complex, maybe not the complexity of Dr. Vinod Nair that he's doing, but they come in with cardiogenic shock, triple vessel disease. You see a patient here. We have to be prepared to revascularize an RCA, LAD, circumflex, put an Impella pump, put the temporary pacer, get a right heart cath. These are all things that time is of the essence in these patients. Brian, I know you're exactly. So the question is, do these skills make the interventional cardiologist expert endovascular specialist? The answer is no. Wholeheartedly, no. And I firmly believe that. Very, very slow to click here. So the problem is that, we're going all over the place. The problem is that many cardiology fellowships right now, today, are heavily weighted in cardiac disease. And I admit that. There are many that do have some PAD vascular training, but it is still, in most programs, heavily weighted in heart disease. And so what I wanted to, if I can click here, that's like very challenging. What I wanted to tell you is my story, real quick. So I went to the University of Pittsburgh, had an excellent training in cardiovascular disease, cardiac disease. And I remember my co-fellow telling me, hey, there's a conference in Las Vegas. They do a lot of things outside of the heart. I knew none of this. I went to Viva in 2008, and I remember the first thing I saw was a live case performed by Jihad Mustafa. And this, I just walked into the lab, and it's kind of interesting. They were doing a complex SFA revascularization. It was, when I was there, Fadi Saab was scrubbed right next to Jihad. I remember this vividly. And my eyes were starting to open up a little bit more. And then I walked into another room, and I saw an operator in Leipzig, Germany, Andre Schmidt performing another live case. And that's when I was sold. I knew immediately, how do I get there? How do I do this? I went back to Pittsburgh, and that was my mission. I want to do this. Now, if you want to know the solution is to train. The training is not very, very easy because in certain areas, you're not going to find your Mr. Miyagi, right? So finding your Mr. Miyagi as an interventional cardiologist can be very challenging. We have to go through, and I wrote a paper on various training pathways after interventional fellowship. Really, you can go for a PVD fellowship at an academic center, PVD fellowship with a private practice, or really on-the-job training as an option. What I really want to focus on is that, dabbling in peripheral interventions as a interventional cardiologist is something that we need to avoid to be true CLI operators. Industry-sponsored courses can be supplements, but I do not feel that they should really take the place of true dedicated training. And so for me, let's see. So what did I do? I found my sensei. I came from Pittsburgh. I went down to Houma, Louisiana, trained with Craig Walker, and he taught me how to treat CLI. And we were able to translate those coronary skills that we had as a foundation into managing complex below the knee, below the ankle disease for these patients. And we were able to also then realize and understand and empathize with these patients who are really in a real sincere, deep struggle. And then I went on to a group that where we realize as cardiologists, our learning never stops, and you need to learn from your partners. Having a good group of partners is really important to that learning process. The other sensei is sitting right here, interventional cardiologist, structural heart intervention. You see Peter Fail droppings all over Louisiana. But what I will say is that learning from Dr. Fail, what you can see is that you can figure out how to put a square peg through a round hole. If you want to learn how to do it, he'll tell you how to do it. He's seen it all. So these are very, very important things that you need. He's gained learning from Dr. Fail. You learn how to treat AAAs. You learn how to manage endo leaks when they occur. And then you can look on and go on to how our interventional colleagues, our cardiology colleagues who do complex interventions, how they help us. Dr. Vinod Nair, when I first met him, I thought he was an IT guru, a tech guru, created our electronic medical record, objective medical systems. But then I realized that what he truly is a master in coronary intervention, complex intervention. But there's a lot of crosstalk between coronary CTO intervention and PAD, CLI CTO intervention. And so we can translate what they're doing to the peripheral space, where we're able to do transcollateral crossing, carts, reverse carts, all types of techniques that are in the cardiology, coronary space can be translated. He does, one thing that we don't have to deal with in the legs, though, is the legs don't fibrillate, but they can certainly amputate, is something that I always say. So what I wanted to move on and kind of conclude here is this is a mission of mine right now with the American College of Cardiology, gaining more exposure for younger colleagues to get into our space, because ultimately what we need are Aaron Gopals, we need McCall Walkers, the younger generation of interventionalists, because of what Dr. Tahara had said earlier. Let me just go back. Is basically vascular specialists are going down in numbers, and really it's not about one specialty. Interventional cardiologists, vascular surgeons, and interventional radiologists, we all should work together for the betterment of our patients. And the last slide here is just telling everybody that we are working together as a team. And that's how we can really, really affect positive change in patients. So next I'm going to move on, okay? You're going to have a hard time with this clicker. I'm just going to tell you that right now, Paul. So Paul Verosi, professor of cardiology, electrophysiologist at the University of Colorado. He's going to speak to us about EP in the ambulatory space.
Thanks so much, Pradeep. So I'm a bit of a strange bird for a number of reasons, but certainly at this meeting, I think I may be the only electrophysiology member of OEIS, and I'm strange for a couple of other reasons too. I see what you're saying. First, my disclosures, and then more relevant disclosures for the purposes of this talk, I'm a hospital-employed physician. I do not practice in an ASC. So I'm a strange bird that I'm talking about ASCs, and I don't do that. So the question is why? Well, I'm an OEIS member because of Jeff Carr, who's sitting right there. He got me involved about 5 years ago because I'm a health services, health outcomes researcher, and my real academic expertise is in building registries. And he brought me in to help build the cardiac module for the OEIS registry. I also serve on a couple of health policy task forces in conjunction with both American College of Cardiology and the Heart Rhythm Society, with which we've been through 5 years of advocacy to try to get the ablation codes open. And I'm pleased about, this has already come up today in the conversation that has come to fruition. And that's also included a couple of expert consensus statements on both same-day discharge for EP procedures and work in ASCs. So that's the why of how I ended up here. So with decreasing number of independent physician practices, many, I think, in our field and EP certainly are starting to see ASCs as a potential pathway to physician independence that we've had taken away from us as a field. But right now, although there is potential for growth, there are a large number of ASCs, but only a small percentage of them, at least as of now, are in the cardiovascular space. And who owns them? Thanks to colleagues who've been able to help me with some of these data, about 2/3 of them are owned by physicians, but less than 1% are entirely owned by health systems. So we don't have to belabor this since this has come up already, but certainly the most recent opening of the ablation codes beginning January of 2026 has been a huge thing that is creating a lot of interest in my world. And what are the real advantages to moving to the ASC for EP procedures? Cost savings for payers for overall lower reimbursement, a less intimidating, friendlier environment, and potentially lower copayment is a real appeal for patients. For physicians, there are some pros and cons here. Lower professional fees, possibly higher overall reimbursement via combined technical and professional fees, and hope of greater independence from hospitals with control, flexibility, and greater efficiencies. The upfront investment costs might be prohibitive for many, and do carry some fairly significant individual risks. For health systems, I could see that there is potentially lower reimbursement but similar costs that might discourage them from going this route. And for all involved, the potential for greater access to care that we're struggling. I mean, we're seeing an explosion of pulsed field ablation for AFib, and even with our greater throughput in those cases, we have just a rapid expansion in the demand for those cases that we just can't get them done, and that's true for all of my colleagues everywhere. In 2026, only a very small percentage of CIEDs and EP procedures are currently performed in an ASC space, and same-day discharge is increasingly common with low risk, hold on. I see what you mean. This is kind of painful. Maybe I'll try this one. Yeah, it's the system. All right, so some key data here from the NCDR AFib ablation registry that several of us, led by John Su and his team at UCSD, looking at 76,000 patients undergoing AFib ablation in the RF era. That risk of major complications is about 0.86%, so a little less than 1%. And this was based in data from around 2019. We looked again for specifically with regard to same-day discharge a couple years later, and just had this published. And what we saw when we look at the trends in same-day discharge, in blue you see the number of patients undergoing same-day discharge after an AFib ablation, and you can see that right around the COVID pandemic, that really started to explode. And even after the COVID has ended, we're seeing a progressive uptick such that now, even in a hospital environment, about 70% of patients undergoing AFib ablation are sent home the same day. This can be done relatively safely. Overall, just moving into a newer era, we found a lower risk overall, 0.7% in the entire cohort, now looking at a much larger cohort of almost 140,000 patients. But it's not zero risk. So what are the take-home points for that? AFib ablation is increasingly performed as a same-day discharge procedure, but in a hospital environment. And if you have, a perforation, you need to open the chest to deal with that. That can easily be done. But moving to an ASC environment, we have to really think differently about the planning for rescue when those things occur. So AFib ablation is low, but not no risk. This joint HRS-ACC task force produced a couple of consensus statements, one on same-day discharge, a second one on actually movement into the ASC environment. The key take-home points are that same-day discharge and care in ASCs should focus on patient safety, access, operational efficiencies, and healthcare expenditures. Shared decision-making should be employed to optimize patient safety, comfort, and procedural outcomes. And then as the flow paradigms evolved with alternate sites of care, such as ambulatory surgery centers, real-world registries to track outcomes should inform future decision-making and support transparency. So in talking with colleagues who are doing this and friends who have already on this road in the EP space, I have learned a few things, and I'll share them, and I don't by any means present this as pretending to have all of the answers. I think we're going to learn a lot together in the coming years, especially from people who are on this path already. I think it's critical to develop a solid business plan. Staff training in EP is critical, and I can't stress enough how much having an experienced staff helps both with efficiency and also helps with avoiding complications and addressing them when they do occur. Understanding the financials. I've heard from several people that it's critical to think carefully and talk with others with experience in building an ASC, including determining how to approach potential strategic partnerships of many different kinds. Understanding the reimbursement landscape is critical. And then equipment and supply cost negotiation are key. For us in our hospital environment, we're doing all of our AFib ablations now with PFA. And for us to do that means we have to have our mapping system. We need an EP recording system. We need the PFA system and the $12,000 disposables associated with it. We need intracardiac echo. There are a lot of equipment and disposable costs, and making those work, I've heard from many who are doing this that can pose some significant challenges. Thinking through and trying to identify the lowest potential risk patients with low risk procedures are really the obvious places to start. Those with anticipated same-day discharge, low probability of complications, and low likelihood of harm, and or a clear feasible plan for rescue in the event that a complication does occur. I've heard from some the idea of start low and go slow, to start with low complexity procedures to build the expertise in the team and then expand after that experience has grown. Clear plans for rescue and transfer to a hospital, including performing simulations, has been key for some. And I would say tracking outcomes via registries is going to be key in this space. We need this because of the fact that the transparency is so critical for what we need moving forward. There's really no one-size-fits-all approach that's going to fit. What occurs in an ASC across the street from a major hospital is one thing, but if you're 150 miles away from or more from a major center, they're very different challenges. Can AF ablation be performed? And I think yes, it can, but likely only after tackling some key things. Starting with less complex ablation procedures is probably the first place to go. Training and developing staff and team expertise, developing a good track record of safety, and then having clear plans for rescue and simulations in place. Cost of equipment and supplies may pose challenges given lower reimbursement, and it'll be critically important to not cut corners in what we're using just because of the reimbursement challenges. A few final thoughts. We really can't sacrifice patient safety in the process of doing this. It won't go well for us or for our patients if we do. Transparency is absolutely critical, which is why registry participation is key. And if we, the EP community, don't get this right, it will be bad for our patients and for all of us in the long run. All right, thank you.
Thanks, Paul. And last but certainly not least, we have Dr. Peter Fail, the cath lab MacGyver, right? Coming up to speak on structural heart interventions. Does it have a future at the ASC?
Yeah, let me see if I can MacGyver the mouse here. So I get the beauty of being last. And then when I saw your talk, I realized that the very first endovascular aneurysm I did was in 1999. When I was the only cardiologist in a room full of vascular surgeons, and that was a little bit of a scary time. So I get the pleasure of talking to you about could or should structural heart disease be done in an ASC arena. These are my disclosures. Most of these are basically around research grants. Medicare regulation allows ambulatory surgery center to perform procedures that do not pose a significant safety risk, generally do not require active medical monitoring past midnight, and do not necessitate a hospitalization greater than 24 hours. And so pretty rigid things, but I think, we kind of push this envelope a little bit. And unfortunately, structural heart, procedures have really ballooned over the past 2 decades. And most indications for what we're doing really are around heart failure, and that, those patients come with a lot of luggage when they hit the table, so that does pose a safety risk. And unfortunately, a lot of them, have multi-system disease, so therefore you have a lot more monitoring, and they do bring a lot to our table. So I think, no matter how safe and predictable these cases can be, reimbursement is going to be an issue. We heard that already. Second-party insurance approvals are going to be a nightmare. So I think it's going to be difficult. I think there's going to be a lot of limiting factors to bringing structural into the ASC. And of course, then you got the Blue Crosses of the world, and you ask them, can I do a fill in the blank? And of course, you get the no. And then, of course, you got United Healthcare, same thing, fill in the blank, whatever you like. I want to do a TAVR, I want to do a clip, I want to do, no, absolutely not. UMR, pick your insurance, nope, you're not going to do that. Humana, no way. And then, of course, Aetna comes in and goes, not in this lifetime. And I mean, I think these are real things. I mean, so I asked my head of the ASC, and I say, hey, can I do, no. It's almost out of her mouth as soon as I call her, her first answer is no. And then, of course, then you got the Medicaid patient who is sitting there, and you'd say, well, can I do this? And then this is your CEO laughing because you're saying, how how much money we're going to lose just bringing that patient to the, and this is real. I mean, at the end of the day, a lot of these ASCs are done, for economic reasons. And so you got to realize, if you're going to lose $20,000 or $30,000 a pop at a patient, your CEO is going to go, there's just no way you're bringing that patient to the clinic, even if you have the contract for Medicaid. So I think there's going to be a lot of areas that are really going to be a problem for us. So I feel that, there's a multitude of hurdles that we need to overcome before we can actually bring structural cases. I do think there are a couple of cases that maybe do. And this is sort of a quick hit list of all the kind of toys that I play with on a regular basis. Some of them have gone defunct since I started. But I think there are a couple of things. So let's start off with just simple monitoring. I mean, we are now doing this in our ASC. This is basically a CardioMEMS monitor, pretty straightforward, a right heart cath, go either from the jugular or from the right femoral. Takes you about 20 minutes to do, and these are pretty good. The big problem here is trying to convince Abbott to let you come and do it. They have to bring all their equipment and done, but it's something that's easily done. We're already doing these in the ASC. I think we could probably do PFOs. They're relatively straightforward. I think a simple ASD probably could be done. I think complex ADs probably not. I can remember the CardioSeal. The CardioSeal we did, if those have been in this field forever, remember the Closure 1 trial that literally shut the door for NMT Medical after it was reported at TCT and said it did not meet its endpoints. But after that, I mean, now you start to see PFOs being done much, much more commonly. So I think this is an area that could easily be done. If you look at this, it's as far as us doing this, bilateral venous access, either 10 to 12 French, RN sedation, ICE guided. We really don't need the expensive one, so that helps us a little bit. Typically takes us about 20 minutes to do these things. I need plus minus venous closure, out of bed, 2 hours. These people go home that afternoon. And so this is routine in our hospital. You could easily do something like this in the ASC. What about TAVR? This has been obviously the darling of the structural arena for many, many years. And I, when I started doing TAVR a million years ago, this was a big deal. So you had general anesthesia, you had TE, you had homeward femoral access, you had large bore. Everybody was swanned up the kazoo. You had a bypass that was a machine that was in the room. It was wet. The perfusionist was sitting there. You had the ICU bed standing by. You had the OR standing by. It was really a nightmare to do these cases, what we think today. And then you had the staff. So even today, I tell my patients, there's going to be about 10 or 15 people in the room. But at that time, you had an interventional cardiologist, a cardiac surgeon, a vascular surgeon if your cardiovascular surgeon didn't do vascular, an imaging cardiologist, a cardiac anesthesiologist, an OR staff, a cath lab staff, clinical people from the TAVR company, whatever the case may be. So you had 20 people sitting in the room trying to do one case. It was absolutely crazy. We had early devices, typically took 2 to 3 hours to do a case. We'd be doing 1, maybe 2 a day. So we had 1 in the morning, we'd had 1 in the afternoon. We thought we were doing great when we do 2 cases a day. 48 hours in the ICU, you had a temporary pacemaker in place. Hospital stays were 4 days. That was routine. So none of these cases were going to go. And then you look at what we're doing today. We're doing RN sedation. No TEE, everything's perked. We do no central venous access. We don't even have the pump anywhere in the cath lab. Interventional cardiologist, the cardiac surgeon still required, and that's going to be one of the hiccups in there. And we have the cath lab staff, and we have the clinical staff from the thing. We're doing 4th and 5th generations. Most of these cases are done in less than an hour. We're doing 4 to 6 cases a day. Most can be done in a cath lab. Some centers are still doing cath labs. We still have a hybrid room. We don't do a temporary pacemaker. We pace on a wire. And, these people are literally going home in less than 24 hours. If you think a lot of them, you're doing a 4 o'clock in the afternoon case, and you're seeing them 7 o'clock the next morning, they're going home. So a vast majority of them. So, you look at this is a thing I saw, OR turnover time, and this is still a problem we see today. It says efficiency is not rushed, but it's designed, and it's very, very true. And I think you can say the same thing between a hospital and ASC. I think that with these turnover times, people to get the job done, it takes a lot longer to do it in a hospital or even in a cath lab compared to an ASC. So what's it going to take? It's going to take a change in the NCD. I think, requiring to have a cardiovascular surgeon standing next to you in the cath lab or in the procedure room at the same time is going to take. It's going to really take patient selection. I think those patients with pre-existing pacemakers, probably pacing is still an issue for us. Excellent femoral access. Obviously, we saw a lot of things with access is going to be an issue. And so that's going to be our nightmare over the time. And then I think overall risk. Do you do a low risk, somebody who is relatively straightforward, or even a prohibitive risk where the surgeon says, no matter what happens to this patient, if they crash and burn, I'm not doing anything. Is that the patient you take the ASC? Not sure. I suspect that it will become as more of a commodity as we've seen it go easier and easier of the days. We eventually will see some of these going to the ASC. Mitral intervention I've done for many, many years. And this has really become the darling of the non-surgical mitral regurgitation fact. And back in 2000, and I think the first one I did was in 2006 with the old NT or the old clip, if you will. Over the years, Abbott sat on this for many, many years, and not until more recently, when they realized that they really had some way to go, that they started really having some evolution. And then, of course, we have the Pascal, which I think pushed Abbott even harder to try to innovate when they have the competitor, where they were the only dominant market. But I think these are a lot of cases that are thinking. This is the complications that we see for M-tier. Fortunately, they tend to be incredibly uncommon. We don't see this very often, but they still pose that significant risk, something you have to be somewhat concerned about as we move forward. If you look at the bleeding risk, the most common bleeding risk we see is actually at the access site. 2 to 4% of the time. We're putting 26 French sheaths in the femoral veins, and so this tends to be the most common. And of course you can see this. You get these perforations, things that go bump in the night. You can see that. This will make your day awful. But fortunately, we don't see it very, very often. And of course, then there's the venous strangulation, especially in the little lady when a 26 French. We don't see this a lot, but every once in a while, you will see this leg get very cool, and you almost have what looks like a phlegmasia. Type of a scenario. It doesn't happen often, but every once in a while it'll occur. We do a lot of access closure with this. I do what's called a belt and suspenders. We will put a Z stitch or a figure of 8 and a perclose, and that combination tends to get our patients up and walking relatively quickly. They even have devices that help you do that. So now you can pay extra money for that Z stitch to help you close everybody's in for a dime, okay? Everybody's in for a dime. But, you know, this is the best way to do it. You know, stopcocks are pretty cheap, and so you can do the exact same thing with a stopcock and make that happen. I do what's called a belt and suspenders. We basically go ahead and put a single per close, and then we go ahead and put a figure of 8 right behind it, and then we'll cut that figure of 8 in 2 hours. Patient's out of bed in 3, and they're basically moving forward. Now, this is a case that brought to my mind when Pradeep asked me, you know, should we do this in the ASC? And this is a lady we did, single clip. She had significant reduction, 45-minute case, and these are not typical. I mean, these cases can go anywhere from 45 minutes to 3 hours. All right, it really is an imaging thing. But this is the first case of the day, and literally, I meet this lady walking down the hall at 3 o'clock in the afternoon. She's walking down the hall, okay? Groin looks good, she's feeling great, and I'm thinking to myself, why am I keeping you overnight? You know, why don't I just send you home? You know, you can go home now. But, you know, we have been so programmed to keep these people overnight that we say, well, you know, go back to bed, I'll see you in the morning, make sure you're okay. Well, what happens when I see you the next morning? She's doing fine. I've been out of bed, I've been sitting in the chair, she's reading her books, you know. So these are kind of cases you kind of think, maybe we could have done this lady at the ASC. Here's the big kicker, though, okay? This damn thing. TE. So how am I going to pay my imaging cardiologist, how am I going to convince my imaging cardiologist that's going to make $170 to stand next to me for an ASC case? $170. That's going to be the big nightmare, okay? So now I'm not paying one cardiologist, I'm paying 2, okay? So this might help us, ICE. Again, you had saw some talk a little bit earlier about ICE coming in. Again, this is a learning strategy. It's a little bit more difficult, it's time consuming, and if you're doing 4D ICE, it's much, much more expensive than 2D ICE. But it is a strategy. So this may be one of those things that evolution, as this goes forward and these become cheaper, we may be able to use this strategy to help us take some of these patients to the ASC. I think a lot of these patients, the vast majority, probably could be done in the ASC. I think there's going to be experience grows, the complications rates continue to drop. Access still becomes a problem. TEs are really going to be the thing of how do we do imaging or reimbursement, or even for ICE, how do we do reimbursement? I think that's going to be a thing. It's still in its infancy for ICE. I'm telling you, when we do the learning curve, we still do TE and ICE together because it is a little bit of a problem. And then we got TriClip. What about going to the tricuspid? This is a nightmare. Okay, from an imaging standpoint, this is incredibly difficult and it's hard to do. Fortunately, I did this years ago. We would do a mitral clip. We would take the clip, put it on, and we'd turn it up backwards, do it upside down, and we would do a tricuspid. Now they actually have dedicated equipment for this. Now, unfortunately, what we found out is that a lot of TriClips are not tried. They're actually, you know, leaflets are 3, 4, and 5 occasionally. So this is an imaging nightmare from that standpoint. And again, this is, I think, the same thing. It's going to be a matter of how do we do a reimbursement from an imager, or how do we do a reimbursement from an ICE. Today, we still do ICE and TE when we do our TriClips because a lot of times it's really hard to see it with TE, and that ICE is really, really good, but you need to use both strategies. Again, a lot more money at the end of the day. The new kid on the block is the Triluminate. This is probably something that's not going to see in ASC. I just Googled this, you know, what are the complications you see with Triluminate? This is sort of the list. The big one that kind of shocked me a little bit was the conduction system, and of course, this is the phone call you get 3 days later. Not that afternoon, 3 days later, okay? This is a person who has an evoke, and you get the call and says, you know, this doesn't look good on his monitor. Now, here's the other problem. This is a timing that you see in evoke. This is a paper that came out for evoke. And notice you see these little bumps that you go through the thing. These things are moving out almost 2 weeks. Okay, so I think this is one of those things that probably in its current iteration we're not going to see in the near future. Left atrial appendages, every one of our, well, I'm not going to say everyone, most of our left atrial appendages go home the same day. You know, so this is one of those things that I think we could probably easily translate into the ASC. Again, TEE is going to be a nightmare. We do a little bit more of this with ICE. It doesn't give us the same resolution, but I think we're getting there slowly as we move forward. So I do think there's a bunch of different things that we will see in the ASC in the coming years. Fortunately, I think there's going to be, the panel's going to be doing that. I think I'm going to be fortunate enough to be retired, maybe, okay? But I think, you know, as we go, it's going to be easily done. I think we talked cardiomims, we talked PFOs. I think some aortic and mitral intervention probably will go. There are going to be some changes in the NCD that are going to need. And then specific patient population. I think all the talks you saw here today had really talked about really identifying that patient that we think really would be safely done in an environment. I think left atrial appendage, I think, is one of those things could easily be done today. Tricuspid, not in its current iteration. Thank you.
Thanks, Dr. Fail. So we're out of time, but if there's any burning questions, speak now, forever hold your peace. Nothing? Very good. All right. So we're going to end the session right here so that we can move on to another session.